Greetings everyone, welcome to another episode of The Professionals You Should Know. This show is about uncovering the journeys of professionals from different industries. And today we have the eloquent and inspirational Dr. Rochelle Pierre, who specializes in anesthesiology. Hello, thank you for joining us today, it's a pleasure.
Thank you.
So, what is it that you do?
A few things.
Okay.
My main job is an anaesthetic trainee.
Oh, what's that?
So I work with surgeons.
Okay.
So when patients go for surgery and they need to be put to sleep for surgery, that's what the anaesthetist does.
Okay.
And also there's like multiple roles for an anaesthetist, but the main one is putting people to sleep.
Yeah, that's surgery. The only one I heard of. What's the other ones?
So a lot of the intensive care doctors are anaesthetists. So most people would like dual train in anaesthetics and intensive care. So they'll spend some of their time doing the surgeries and then some of their time working on the intensive care ward.
What would they do in the intensive care ward?
So basically, in intensive care you get like the sickest patients within the hospital. So patients that need some form of support. Right. Usually it's for respiratory or breathing support.
Okay.
So a lot of the patients in intensive care are on ventilators, breathing machines, to support their breathing. Other things that we can do in intensive care, so some patients might require support, for example, for their kidneys. So we can put them on a dialysis machine in intensive care. Other people might need support if they have a severe infection. So if they have sepsis, they might need support with their blood pressure, for example.
Right. Is that where their whole body breaks down? Like
yeah, so sepsis is basically an infection that kind of affects your whole body. So a lot of the time people will come in and they'll have like a low blood pressure or their heart might not be pumping properly. So in intensive care we can give them medications to help with that, to support their blood pressure and help them to recover from the infection. So it's kind of like
two extremes. One is, you're just making sure the patient is safe while going under surgery, and the other one is making sure that their life is is stable.
And in anaesthetists are quite important during what we call cardiac arrest. Okay. So this is basically where someone's heart has effectively stopped beating, and anaesthetists are required to look after their airway. So we will put a tube down to help them breathe and support their breathing whilst CPR and things are going on. So
that's interesting.
Yeah, quite a few sort of different roles in the hospital.
A few streams as well. That's amazing.
Yeah.
So how did you get into it? What was your story?
So I went to Essex University, studied biomedical science, and then it was there I was like doing science, worked in a lab for a bit, and I was like, I really just don't want to do this for the rest of my life. What else can I do? And then one of my lecturers was like, oh yeah, like you're doing really well, you should think about applying to medicine. Okay. So I was like, okay, I'll apply, see what happens. And then I ended up getting a first, so I graduated.
Wow, okay.
And got a place to study medicine.
Is that the same university or a different university?
No, so I studied medicine at Barts in London. And so I never really thought about becoming a doctor, and I think it's because you don't have those role models around, you don't have those people to look up to. So I think now we're trying to create that space where there are positive black role models, especially in the medical and dental field. And so in that I set up an organisation.
Nice.
It's the British Caribbean Doctors and Dentists Association, just to give that visual representation, so that people can think about studying medicine earlier.
Oh, that's a good idea.
And then went through medical school 5 years and decided that anaesthetics was for me. Yeah.
And you said you was into music as well.
Yeah.
Is that what you do on the side, or?
Yeah, so I learned to DJ when I was like 14.
Okay.
And kind of stopped for a few years. Obviously, life happened. But then probably about 3 years ago, I was like, no, actually,
you like music.
Still love music. Still want to get back into it. So yeah, on the side in my limited spare time,
I can imagine.
I DJ. I play out professionally as well. So that's kind of like my other side to my journey.
Okay.
Yeah.
So if there was like carnival this year, we would see you there?
Yeah. So, I'm part of a carnival band, UCOM, so I'm the DJ for them.
Wow.
And then in terms of anesthetics, I think I found that it's a speciality where you can really make a difference in someone's life. I know all specialities you can, but in anesthetics it's more of an immediate, difference, and you can see an immediate reward because you attend like all of the critical situations in the hospital. So if someone, as I said, has had a cardiac arrest or is really sick and they need intensive care, then anaesthetists are usually one of the most important people there. And I feel like that for me, I don't really like a lot of admin and a lot of paperwork.
Okay.
And in anaesthetics, there is obviously with every job there is, but there's nowhere near as much as other. Yeah.
But I thought, because obviously you're dealing with the most critical patients.
Yeah.
There would be more like admin alongside that.
So there isn't. So it's difficult to explain, but in medicine, like when someone comes to intensive care, once they're discharged from intensive care, they go back to a ward. So the paperwork is kind of just about their stay whilst they've been in intensive care, and just telling other people once they're discharged, kind of handing over the patient. Right. Whereas other wards, there's a lot of other paperwork.
So you're smart. It's why we do decisions.
Yes, and it's a lot of hands-on stuff. There's a lot of practical procedures.
So
you have to do things like getting vascular access. So like if someone's on a drip, and they pop like a cannula, tube in their hand.
So you would do that.
So a lot of the time, like people on the wards can do it, but if someone's really difficult, then the anaesthetist is called to kind of come and sort them out, basically. And we use like ultrasound machines. We put lines in.
Is that the ultrasound for like where the women?
Yeah. So it's
that kind of ultrasound, like where you see tendons and stuff.
Yeah. So they're all the same, really.
Okay.
It's just there's different types of probes that you can use to see different things. So the ultrasound that women have for their belly, you can use it to see tendons, as you said. You can use it to see, like, look at people's heart.
Why would you choose that over an X-ray? Because I thought that would be the...
Because with ultrasound, it gives you kind of a live image. That makes sense. Like an X-ray would be like a still photo, whereas ultrasound gives you kind of a video, so you can see what's happening in real time, basically. And you can use it to get veins and put cannulas in.
Really?
Yeah.
Oh, I didn't know that.
Yeah. And we also use it actually for people that are going for surgery, and for example if they're having surgery on their shoulder and they don't want to be put to sleep, we can do things what we call nerve blocks, which is basically we put local anaesthetic around the nerves that supply the area, and use ultrasound for that as well. And therefore they stay awake throughout their surgery but they don't feel anything.
What? So these the drugs that you use, they must be really powerful, I'm guessing.
Yeah, they are. You have to be very careful,
Why?
because if you give someone too much of any of the drugs, then it can cause serious side effects and can even lead to death.
Really?
So the training, like to be an anaesthetist, is really like, especially because we have to do exams as well, and the exams are kind of known to be the most difficult in medicine. So
Really?
this is what I've been told. I haven't done them yet, so I'm I'm sure I'll find out. But
so what part are you? What part are you on your journey?
So I am a CT2. So basically the way, I'm sure it's been explained to you before, but the way medicine works is you go to medical school. Right. Then once you finish, you do your foundation year. So you do 2 years of foundation training. Yeah. And then you apply for core training. Yeah. Which is the CT part. Okay. So CT1, CT2, it's like your first 2 years of core training. Right. And then you go into registrar training after that. So depending on your speciality, with anaesthetics, it's a 7-year program, but different specialities are different. So I've got a long way to go. I've got about 5-6 years to go.
Are you enjoying it at the moment?
I'm loving it. I really am.
So this is definitely you're gonna stay this for
as long as I pass the exam.
Oh, you will.
Yeah.
Okay. Wow. So so what was the story that kind of reinforced that anaesthetist is definitely what you wanted to do, or what you want to do and continue to do?
I think so. There's been a few scenarios that we've had.
What's your one, the main one that really just jumps out at you?
So we had a patient who came in bleeding, like very unwell. Okay. And so with anaesthetics, there's like the elective surgery, which is patients who are booked to come in for surgery and everything is planned out. And then there's also the emergency surgery, which is patients who come into A&E who are very sick and then need to go to surgery straight away. So with the emergency surgery, as I said, this patient's bleeding, and we needed to get them to surgery straight away to stop the bleeding, basically. Before we took them to surgery, they're very unwell, like low blood pressure, things like that. And you have to really act quickly in order to save someone's life, basically. So I think without sort of, breaking confidentiality, giving too much details, it was more of that patient was really, really sick. We had to give them blood transfusions, put in loads of different lines, get the surgeons in, and they had to go to intensive care afterwards. And I think that kind of made me realise just how important anaesthetists are. I think everybody has a misconception that anaesthetists are they just put patients.
That's what I know you love.
Literally.
That's what I know you love.
A lot of people don't even think anaesthetists are doctors. Even I, when I was, during my training, I just thought, anaesthetists just put in cannulas, they just come and help. But from actually starting the training, I've realised that they do so much more and they're so important.
Imagine you're like the first line of defence for anything anyway. Because obviously without you guys, number one, that couldn't be done, as well as when persons are, in a difficult state. You're able to manage them and make sure that they, come around. Wow, such an important job. I think it's important for people to understand as well what anaesthetist does. Even my parents, I remember I told my dad I'm going to be an anaesthetic trainer. He was like, you don't need training to that. You just put people to sleep. It's easy. Constantly had to explain to him, this is what we do. This is what we do. So I think he gets it now. But I think there's a lot of people that don't really. And do you work closely with anyone then as well? So with anaesthetists, I know you work closely with surgeons. On intensive care, do you work closely with physios or nurses as well? So it's very multidisciplinary. So in the theatre department there's ODP, so operating department practitioners. So they're basically anaesthetic assistants who you have to have them for every case. You can't do any case without them. So they help you with everything from
bringing the patient in, checking them in, putting them to sleep. So you have those, and then you have the scrub nurses as well, and the surgeons in theatres. In intensive care, there's an even bigger team. So there are the nurses, there's healthcare assistants, there's physios, there's dietitians, there's pharmacists. I think those are the ones I can think of at the top of my head. But yeah, there is a massive team that you work with.
So you know when you say you go into surgery and obviously put them to sleep, and is it like do you have to calculate the drug to put them to sleep? Do you have to know their like body mass and stuff like that? How do you form the...
Yeah, so a lot of it is based on body weight and age. So for children, obviously we'll give different doses.
Is it of the same drug, or is it different drugs? Or
generally the same drug.
Okay.
There are some drugs that you can't use in children or below a certain age, but generally we use the same drug for adults and children. It's just the amount that we give. And obviously if you're larger, you'll require more of the anaesthetic to put you to sleep. So.
And are you monitoring this all the time when they
Yeah, so from the moment they step into the anaesthetic room, we put monitoring on. So we monitor the heart rate, we monitor the oxygen levels, we monitor breathing, monitor blood pressure, and that keeps going throughout the whole of the surgery. So that we know that if anything changes, then we can act on it very quickly. We have like a lot of emergency drugs that we use as well. So if anything, like the blood pressure goes low, we can give drugs to bring it up. So yeah, there's a lot of monitoring throughout, and we have to stay with the patient for the whole surgery. You can't leave them at all.
Really?
Yeah.
So like if a surgery is like, I don't know, do you know what type of surgery do you normally get into? Is it all in every different type?
Yeah, so at the moment, because I'm still doing in my early days of training, we do pretty much everything. So for example, we'll do like general surgery where people will have like parts of their bowel removed. We'll do gynae surgery, we'll do urology surgery. People might have stents, like stones, kidney stones. We'll do things like that. People with like appendicitis or abscesses. We also do like trauma. So if someone comes in with like a fractured arm or leg or something. And then there's the obstetric side, which I've not done yet. But they do, like epidurals for pregnant women. Or if women's having cesarean section, then you need an anaesthetist there.
So you guys are needed all the time, basically.
Pretty much.
Wow.
Yeah.
Okay. And in your opinion, who do you feel that values you more within the industry? So it would be like patients, governments, colleagues. Like, who do you think that gives you the most appreciation for your service?
I think that's a difficult question. I feel like it depends on the situation. I think in obstetrics, anaesthetists are, again, I've not done obstetrics, but I can imagine that they're valued because, again, anaesthetists are required for pain management as well. So I think I'd say probably pain patients might value anaesthetists the most.
I didn't think about that.
Yeah, so things like epidurals are basically to manage the pain of a pregnancy, of childbirth. And then, if someone's had surgery, they can have an epidural as well. Or what we call a spinal analgesia, which is to give local anaesthetic into the spine so that it...
Are they the same thing, or is spinal...
So usually an epidural is done a bit at a higher level than a spinal. And also with an epidural, we put a plastic tube into the back so that you can top it up and give boluses of pain medication. Whereas with a spinal, it's just one injection and it lasts for about 6 hours or so.
And is this like, do you use a machine to show you where you're putting in the spinal? Or is it just, you obviously, I know you know the anatomy very well, but is it like, okay, feel, okay, press?
Yeah. So it's generally anatomical landmarks. So you feel down the spine. You can use an ultrasound, but most people don't, because in most people, like if you're not very large, it's quite, if you've got quite a slim back, it's quite easy to feel, you feel for the hips and then you feel down the spine so you know what level you're at.
Right.
So yeah, a lot of it is just a landmark technique.
What level do you go in? Just curious.
Usually L4, L5. Yeah, that's where we kind of aim for. But you can go one higher if you're struggling.
And like, do you know? Of course, is the needle a certain depth that you have so it doesn't like actually touch the cord, or has anyone ever touched the cord? Or
yes, so that's one of the side effects. So the level that we go for the spinal anesthesia, you can't touch the spinal cord because the spinal cord ends much higher up.
Yeah, L1, right?
Yeah, but what happens is the nerve roots come down. Yeah. So you can tickle those nerve roots. So sometimes when you're doing the procedure, the patient might say, "Oh, I've got shooting down my left leg or my right leg."
They're alive. Not alive. They're still breathing. They're still awake.
Yeah. So we can again use spinal anesthesia. You know how I mentioned about nerve blocks before?
Yeah. Oh, yeah.
Yeah. So you can use a spinal anesthesia for some surgeries that are like usually things like an abscess or a hernia, or even like hip replacements they tend to use.
Really?
Yeah.
So they're awake and they just use the block?
Yeah. So what it does is it blocks from about just above your belly button all the way down your legs, so you can't feel anything. No.
And how long does that last for?
Usually about 6 hours.
6 hours.
But I mean, in terms of doing the surgery where you have a complete block, we'd say about 2 hours.
Oh, 2 hours.
But for it to completely wear off,
6 hours.
It's about 6 hours.
And say, for example, I don't know, the surgery was more complicated than it was, and you only done it for 2 hours. Would you then go in again and do it another one?
No, so we generally don't. In that scenario, we may then put the patient to sleep. Because then it means it's much safer for the patient. We don't like to, and they're already positioned on the table. So for example, if they're having a hip operation, they're already in that position. We can't then turn them because you have to be in a specific position to do the spinal.
I see.
So yeah, we generally would just put them to sleep after that.
How would you put them? Would it be like gas or?
Yeah, so usually when we're putting someone to sleep, there's 2 ways that you can do it. The most common way is to, as I mentioned about the cannula, you have a drip, and we give you an injection.
Okay.
That puts you to sleep.
Really?
That's
how quick?
Like 30 seconds to a minute.
That quick?
Yeah. So
okay, that's the first one. What's the other one?
The other one is what we call an inhalational anesthetic.
Right.
And basically, once we usually use the inhalational agents once we've put you to sleep with the injection to maintain your anesthetic. So we use that to keep you asleep. But in children, we can use that. It's a gas that we use. They just breathe it in, and it takes longer for people to fall asleep that way.
What's roughly the time limit?
Probably a few minutes.
Right.
Yeah, because you have to wait for you to breathe it in, for it to get to your blood, build up in your blood, then get to your brain. Whereas if you give it straight into the vein, it goes very quickly. So yeah.
That's really interesting. Your job is really interesting.
Thank you.
I've learned a lot already.
As I say, most people just think, sleep, it's nothing. But yeah. And there's like a fine balance as well. If you give too much, as I say, it can be fatal. So you have to really know what you're doing.
Wow.
Yeah.
I can imagine it. Training must be intensive.
Yeah. It's very busy, but it's enjoyable. So,
So what's like a normal day-to-day for you then?
So it depends. If I'm on like an elective list, as I said, what would happen is we'd go in usually about 7:30, go see the patients. So you explain to them the anaesthetic, you'll explain, you know, the drugs that you're going to be using. If you're going to give a general anaesthetic, which is putting them to sleep, or if you're going to do a regional anaesthetic, so that's like the block that we spoke about, whether it's spinal or for the shoulder or knee or... so you discuss that with them, and you'll discuss like side effects that they might expect after the surgery.
What kind of side effects are there?
So it depends what kind of anaesthetic they have. So for like a general anaesthetic, some people can be allergic to it. There's certain conditions that run in families that, you know, means that someone might not be able to have a certain medication.
These are like more inflammatory type of conditions, like RA or something like that, or
it's more like a specific genetic condition that can mean that they're predisposed to having a reaction to the anaesthetic, and that reaction could be fatal if we don't know about it. We take their family history, we ask if they've had anaesthetic before, we ask if anyone in their family's had any problems with anaesthetic, because you need to make sure that you're aware. If they say yes, this condition runs in the family, then we don't use that type of anaesthetic. And then just general things like if you're asleep, you're not moving around as much, so there's like risk of damage to the nerves, you know, like when you sleep funny on your arm, things like that. And then with regional anaesthetic, again, there's a risk of damage to the nerves because you're going through close to where the nerves are, and then bleeding, infection, because you're going through the skin. We just tell them everything that they need to know about the anaesthetic. Get to know the patient a little bit, know their history before we put them to sleep. And then after that, we'll go down. So you go to prepare all of your drugs, which takes forever.
I can imagine.
So you always have to have your drugs that you use for induction, which is when you're putting them to sleep, so the ones that you inject. And then you always have to have the emergency drugs in case something happens, because things can change very quickly in anaesthetics.
So you always have to be alert, I'm guessing. You can't.
You have to. So I think the consultants have probably got to a level where they can probably chill a little bit, and then you like all your machines have alarms, and you have to write the patient's observations every 5 minutes.
5 minutes.
If the patient is quite sick, then you'll write it less than like maybe every 2-3 minutes you'll check.
So for the hour of the surgery, every 5 minutes or every 2 minutes is. You have to, because there's some subtle changes that you may not notice if like your alarms might not pick up. But if something majorly, like for example, the blood pressure dropped very low, the alarms will go off, so that will alert you. But if it's like slowly trending downwards, it's not going to tell you, so you need to be able to see that. That's cool.
That's
really cool.
And then I think after you've drawn up all your drugs and things, patients will come down, you'll go through the surgery. Once the surgery is over, you wake the patient up and you bring them to recovery.
Is that a drug that you put in to bring them to recovery, or is it just...
No, with the... As I mentioned, the anaesthetic, we use the inhalation agents to keep people asleep. They wear off very quickly. So once you turn it off, within a few minutes, the patient starts to wake up.
That's cool.
So you just have to basically wash it out of the system. So there are... if you have given a patient a muscle relaxant, for example, then you have to give a drug to reverse that effect. Because that would be a horrible experience for the patient. Like, they'd be awake but not able to move and probably not able to breathe very well. So yeah, you'd have to give a reversal for the muscle relaxant. But otherwise, no, you just turn it off and they'll wake up.
That's cool.
Yeah.
Oh wow, you do an incredible job, incredible service.
Thank you.
All right. So what we're gonna do now, we're gonna go to a different little section. It's we call it rapid fire or rapid round. So basically, what I'm gonna do is I'm gonna ask you 3 questions. It's either gonna be a pick a choice or a yes or no.
Okay.
Yeah. So it's gonna be closed.
Okay.
All right. And if you want, you can fire one back at me, but that's only if you want. Okay. All right. Cool. So, all right. For our first question, has anyone woken up before they were supposed to after giving anesthetics?
Yes, but I've not personally experienced it.
All right. So for our second question, what's the best natural way to put you to sleep? Chamomile tea or breathing exercises? Yeah.
That's a good question. I like both of them, and I use both of them.
Okay, which one?
Ooh. I guess breathing exercises, because it is more natural, isn't it? You're not ingesting anything. So yeah, we'll go with breathing exercises.
Physio, yeah. All right. For our third and final question, all right. Has anyone refused anesthetics and just tried to soldier a surgery?
We wouldn't do surgery without anaesthetic. So if they're refused, then they don't get surgery. But people have tried to like stay awake, but they never do.
They never do.
Like, I'm gonna be awake. You're like, okay, good luck. But yeah, they never do.
Okay.
So,
No. Okay. Yeah. Cool. Fair play. In your personal opinion, where do you think the healthcare industry will be without your profession?
Non-existent.
Wow.
Yeah, I think it would be pretty difficult to run healthcare without an anaesthetist, unless there was something to replace it. But I don't think we're very replaceable.
Is it irreplaceable? Okay, and that's I'm guessing for any part of the hospital, especially for A&E and obviously.
Yeah, because we're needed in surgery, we're needed in intensive care, we're needed for all cardiac arrests, we're needed for all what we call medical emergency calls, we're needed for paediatric patients, we have to transfer patients as well, I forgot to mention.
What do you mean?
For example, if a hospital's not able to offer treatment at one hospital and the patient needs to go to another hospital, then it's the anaesthetist's job to go with them in the ambulance.
Really?
Yeah, so
wow.
yeah, we transfer patients to different hospitals with the ambulance crew. And no other like speciality is trained to do that. So yeah, I don't think they could exist without us.
Fair play. Yeah. And do you think anything is missing from your professions? Some people say work-life balance, some people say status, some people say recognition. I don't know. Do you think anything is missing?
I think maybe recognition. I feel like, as I said before, like a lot of people don't actually know what the job of an anaesthetist is. And I think they work really hard, and it was very prevalent like during the COVID epidemic.
Yeah.
Anaesthetists were like right at the forefront, and you know the hospital relied on the anaesthetist to get patients through. So I think definitely recognition.
Because I can imagine, because everyone was going on intensive care, I guess. So you guys were needed the most.
Yeah, and we had to sort of intubate patients and put the tube down. And anaesthetists are the only people that can do that. So yeah, I think recognition probably.
So for our final questions, do you see your profession progressing in any ways, which could mean, I don't know, certain different technologies to make your profession more easier, different ways to get to become an anaesthetist, just something of that nature.
Yeah, so I think there's a lot of research going on constantly within the medical field, and they're always improving things. I think in terms of anesthetics, probably the way that we intubate patients. So now there's lots of, I think back in the day they just had, what we call a laryngoscope, which allows us to look down the throat.
Right.
Now they've progressed, they've got video laryngoscopes. So
is it still going down the throat though?
It still goes down the throat, but instead of us actually looking into the patient's mouth, you have a screen so you can see. So I think there'll probably be more advances in
what about
that side.
a pill? They will swallow a pill and they'll be able to see it. I don't know.
I think there are things like that, but not. It wouldn't be helpful for anaesthetics. Okay. But I think also the way that training is going, this is more of a political thing, but I think they're trying to basically bring in sort of anaesthetic assistants who would do some of the roles of the doctors, which is not necessarily a good thing, but I think, lack of funding, and there was a lot of issues this year with people progressing in their training and getting jobs and things like that. So I think it's probably in the next sort of 10 years, it's going to change as a profession, but
really?
Whether that's a good thing or not, I don't think so. But
okay, because of course you guys go through an extremely amount of training.
Yeah.
For someone to just do some.
Yeah, I think it's very simple very easy to train someone to do a procedure.
Yeah.
But then for them to have that knowledge. And understanding, that's a different level.
Yeah.
And if anaesthetists train for 10, 15 years, then having someone who's trained for 3 years doing the same job doesn't quite balance. Yeah.
Wow.
Yeah.
Okay. And is there any new I know you said that there's a video camera, but is there any new technology? So I know you said you inject it for a local anesthetics. It could be a spray or I don't know, something that's more or less invasive to numb the area or to do surgery or anything
I think
that?
there are there already are local anaesthetic sprays and gels and things that we use for children. Yeah, do you know when you're doing a cannula for a child?
Yeah.
Because it can be quite painful for them. They put local anaesthetic on their hands, and it does work. But I think with surgery, the fact that it's much deeper,
you need it.
I think it's unlikely to. Yeah, I don't think it would work in that way, no.
Okay. For our final question, as you know, the show is called The Professionals You Should Know. Who's another professional that you think we should know? Just one.
So, it's actually one of my friends.
Okay.
One of my DJ friends who is also an engineer.
Okay. Okay.
So, I think it would be interesting to get to know about him and
what he does.
His name's DJ Paulie, but he is also an engineer as well.
What is it? What kind of engineer? Just an engineer.
Find out.
I'll reach out. No, but it's been a pleasure of having you here. I've learned so much, and it was great to have you on.
Thank you so much. I've had a lot of fun.
Same. All right, thank you, and I hope to see you guys soon.